So today's meetup, as the title says, we will focus on the AI agent use case on clinical diagnosis. This meetup is majorly based on a paper called AgentClinic. I believe it's the first paper introducing a multimodal interactive agent benchmarks to evaluate the AI agent in the clinical environment. To start with, I think this thread is all about whether AI can help improve the medical diagnostic accuracy. So there are lots of web pages. So if you search on the internet, or you can ask the ChatGPT, for example, I bet you will see lots of articles and news in this field. I think right now it's still a very actively developed field. People are investigating into the ChatGPT-like or Gen AI-like models, how they perform on its own, right? So let's just give the medical questions to the GPT-like model. What is the accuracy of the answer from the GPT model by its own? And also we want to see whether it is a good assistant for the doctors and physicians to improve the accuracy of diagnostics in practice to kind of make it since I bet the medical staffs are also short-staffed, right? Like whether AI tool can help close the clinical gaps and make the diagnosis more efficient and accurate. So if you look at Google just released a medicine Gemini. So I think Google is releasing a series of Gemini model, and also they are also developing the special LLMs just for medicine. So this is a family of research models specifically fine-tuned for the medical domain. So you can look at the Matt Gemini. So people may also ask a question like, when is a good time to fine-tune a model rather than just use RAG, right? What if you just use a general LLM and then you pair it with a medical database? Well, will that be sufficient? Well, based on the data points I see and also the trends in industry, I do not think that is sufficient because the LLM, in order to better have a deep understanding of the medical knowledge and also the kind of the reasoning, right? Like for the diagnosis is also like a reasoning track to make the right conclusion after seeing all the evidence. I think we do need more specialized LLMs just focused in the medical domain. So that's why I think also Google why they trained Gemini just for medicine. I also find this chatbot online. It's called RichRx. I think it helps you to understand the medicines, like what prescriptions or drugs. So I think they also have lots of like example Q&As there, so you can try. The good things on this chatbot is if you ask, for example, if a doctor asks this chatbot, what labs do I need before taking this medicine, for example, this prescription, and then it will gives you an answer, and also it gives you the references, the source, and also more information about this prescription itself. So after looking at the database, like the interface and this interaction, I think it may help the doctor also to kind of follow the best practice and also to gather all the information in one place. So if it's like accurate and effective, I don't think it's a good assistant tool to the doctors. And then when we come to building LLM for medicine, there are two or more major static benchmarks. Static, I mean just static Q&A, right? So you just present one question to the LLM, and then LLM try the best to select the best answer or just answer that question in text. So one benchmark, of course, is the United States medical licensing exam. So this exam, I believe every practitioner has to pass this exam in order to be a doctor. And then the pass score for human is only 60%. As long as you pass 60% accuracy, you pass the licensing exam. And initially, the LLM, the score on this exam is like 38% accuracy from 2021, and it has been increased to above 90% in June. So I bet right now, since it's in 2025 June after a year, I believe this score has again increased to much higher than 90%. And human expert score is 87%. So in terms of the static Q&A, the LLM does has advantage there. If we assume there's no data leakage, which to be seen. So some people debate that, well, this type of information may be already leaked in the pre-training data sets, and that's why they have such a high score. But I think it's still all under debate. But right now, I think the data leakage is also being paid more and more attention, and I hope that the scores will be more unbiased right now to genuinely reflect the capabilities of the LM. Another important benchmarks for medicine is the medical Q&A. So this is a Q&A multi-choice questions to evaluate the LM understanding of the again diagnosis of the scenario, right? Providing all the patient history, information, symptoms, exams, all at once in a question, and then you ask the LM to select. So there are multiple choices of disease, potential disease, and then you ask the LM to select which is one that relevant for the information presented. So this benchmarks, initially it's only around 40%, and right now it's also like above, I believe above 90%. Yeah, 91%. Right now, this is like 2024, like June, the Medicine Gemini model achieves the best performance on this benchmark. Well, the Gemini also improving, right? So I think they may still on the frontier of the performance for the Q&As in medical diagnosis. So this is the kind of the prior state of the art before this paper. So this shows what that data set looked like. So basically it's like questions and the options A, B, C, D for you to select based on this information presented over here. So it's like a multi-choice Q&A question. So the LLM needs to understand all this patient history, symptoms there, and then select which is the most likely the cause for the patient symptoms over here. Okay. So this paper raised a question is like, what is the limitation of this existing benchmarks? What is the limitation of the results we just see, right? So besides all of those mentioned, if you compare the medical Q&As to clinical process, clinical process is more than that, right? It's not one-time Q&A. It's not like you present all the information to the doctor and the doctor say, oh, you are diagnosed with this, take this medicine, that's it. It's not like that, right? It's usually requires a sequential decision process. It involves lots of interactions with the doctors, and then you need to take some exams, and then the doctor check the exams results, and then they may, prescribe you another exam, or they may or may not conclude right away, right? So it's a sequential decision-making process rather than one-time static Q&As. And also, in practice, I think the doctor does need to handle the uncertainty and the risk, because usually it's not like 100% 100% information are all available, because that will come with the cost, right? It's unlikely that you will ask all types of exams to the patients, which will be very costly, and also the patient may be overtreated, right? So we want to avoid that, and also the diagnosis also cannot be 100% accurate, as I just heard the example there. So the diagnosis can also never be 100% accurate with zero uncertainty. There will be never like that. There will be always diagnosed with certain uncertainty, but that will be the best diagnosis decision based on the limited information presented. So it will highly depends on the doctor's experience to handle this uncertainty and risk. So that's the gap, right? So it's not enough that we just evaluate the LM on the static Q&As, which is totally different process from the clinical process. Okay. How to overcome the limitations? So this paper, I think, is making the first attempt to create a new benchmark for the medical diagnosis in an interactive and dialogue-driven process. And also it allows the doctor to make sequential decisions in the environment, in a simulated environment, that they can have a dialogue with the patient, ask about symptoms, lifestyles, or histories, family histories, and then they can order the appropriate medical exam one by one, that as the doctor see fit, and then also because they may take X-rays or MRI, right? So there will be medical images taken, and then the doctor, well, there will be an exam. There will be the examiners who will write the findings for the images, while the doctor needs to understand both the images and the findings from the images there from the lab. So this is targeted at a sequential dialogue interactive benchmark for the clinical decision making. Well, if it's interactive and involves multiple roles, and by nature it's a multi-agent system. So it's and also it has to be multimodal, because in medical field, it's all text, images, and maybe video sometimes, but at least you need to handle both text and images, and also need to handle the kind of the tables, right? At least with the pairwise the count of white blood cells and then the field and the corresponding value there. So what we need is a multimodal agent framework. In this framework, I don't think they they introduce lots of complexity since it's the first attempt, but they introduce a major role such as a patient, the doctor. The device is for providing the results for the exams. And the moderator here, you can think about it as the AI judge to say whether the doctor's diagnosis is correct or not. And then for this agent, yeah, it has a LM backbone, which can be LM or VLM, which can handle the images. And then there will be a context to the agent, such as the patient may have the context about all the symptoms they know. The doctor may have the context about the prior notes he or she takes, and then the guidelines. And also the device or the measurement agent will have all the images and the findings from the images and potential suggestions from the measurement. And then the moderator will be just, if you give the diagnosis from the doctor, the moderator will compare the diagnosis from doctor to the ground truth they have. And I will talk about like how they get the ground truth they have, and then they will evaluate whether the doctor agent is performing accurately. In this framework, they also introduce biases, like the recency bias and racist bias, to see how that can affect the diagnostic accuracy as well. So this is the agent, and then this is the AgentClinic. So they try to create an environment to simulate the current clinical process. Like in the beginning, the doctor may just chat with the patient agent, right? Like to ask about the symptoms, ask about the family history, or ask about the habit, like do you exercise, do you eat healthy, all of that. So the doctor will have a dialogue conversation with the patient and then to gather the information. And then the doctor say, oh, I will send the exam to order a chest X-ray to the measurement agent, and the measurement agent is able to return both like the signals or images and findings from the exam. And then so there will be multiple dialogue interactions until the doctor agent say, oh, this is my diagnosis recommendation. And then it will be sent to the moderator agent, which has the ground truth, and then it will compare whether that diagnosis is accurate or not, so that we can evaluate the doctor agent that way. So over here, they also think about the doctor needs to be empathetic, right? So it's not just providing knowledge, but also providing care to the patient. So we may also need to care about whether the doctor is like what is the ratings of the doctor, whether really it cares for the patient. It's not just a knowledge provider, right? Yeah, and what is the level of the standard of the care? So this is kind of like as an AI judge to evaluate the how effective that doctor agent is. Yeah, question?
Yeah, I think they don't do anything to sort of improve the bedside manner of the doctor in this agent. And so I think that sort of highlights something that you mentioned earlier, that you don't really want to just take a stock foundation model and try to use it as a doctor. It needs to have some special additional training,
Mhm.
such as empathy and how to have good bedside manners if you're a doctor and so forth. That all goes into their training.
Yeah,
And I think one of the things that they found in this paper was that the bedside manner wasn't necessarily very good.
yeah. That is all the ethics AI that you need to care for when you trying to train the another special LM for the for yeah for the medical practice. Cool. So this is just some example in the simulation dialogue, right? So this is like a doctor trying to communicate with the patient. So there will be a long dialogues. And then you will expect the patient just to respond with exact information, rather than the patient is going to do a long presentation to you, like the static Q&A, like showing all the information all at once. It's not like that, right? So it's usually like what doctor asks, you just respond with the information, like in one or two sentences. That's the what we like how we communicate with the doctor. And then the doctor say, okay, given this, I need to, the agent say like, I want to request a scan. So this can be considered as a tool for the doctor. And then it will goes to the measurement agent. Measurement agent has all the information about the exams. Well, return the exams for the corresponding patient. And then the doctor, if it's ready, it says diagnosis ready. And this is the conclusion there. And then you will send to the moderator, and then the moderator will compare the one branches to say, oh, whether this output is correct or wrong. Then we can evaluate what is the accuracy for the doctor agent. So as I mentioned, right? So this agent build the data sets or build the knowledge base for this agent actually are sourced from the real clinical use cases, so that we make sure that the symptoms, the exams, are related, right, to that disease. So all these simulation cases are sourced from these three source, like including the licensing exam, including this electronic de-identified electronic health records, and also this case challenges, the actual real-world medical challenge cases. Well, it already has the symptoms, exams, and the diagnosis, the ground truth from these cases, and then they separate the information by provide what is only needed for that agent. For example, the doctor in the beginning do not need to know anything, right? The doctor doesn't know anything at all. So they just know, oh, I need to diagnose this patient. And also it has access to a set of tools. And then the patient agent knows about the history, the symptoms, and the exam agent will have the all the exam images and findings for the measurement. Lastly, the moderator knows about the ground truth, right, from these clinical cases. They know about what is the final the corresponding diagnosis for in these use cases. So this simulation is actually sourced from the real clinical use cases to make sure that it's really relevant. It's not like a fully synthetic data set. It's actually sourced from the real clinical cases. So this is what that use case data they have curate, right? So this is the objective for the doctor. And then for the patient actor or the patient agent, they know about the age, the history, symptoms, past medical history, et cetera, here. And then the examination agent will know about all the physical examination findings, right? So the vital signs, the cardio examinations, and all of this, both text and images as well. And then they also know some of the test results. What is the findings from that? And then the moderator or the AI judge agent, this will be provided to the moderator agent, which is the correct diagnosis, right? So we know the moderator know about what is the correct diagnosis for this. And then once the doctor agent makes the conclusion, then the moderator is able to say whether that doctor agent is correct or not. Okay, so this is what the data looks like. And then basically this information are split to serve as the context for each agent. And then they will start the conversation from there. Okay, so that's the setup. So how to set up the prompts for each of the agent. So yeah, so usually the prompt is to start with you are a XXX, right? So you are a patient in this, and then you will be asked about by the doctor, right? And then your answer will be only 1 to 3 sentences in length. That we do not expect the patient to just provide all the information at once. We do expect the patient to mimic how a real patient in real world is responding to the doctor, right? So you just provide brief response. And we expect the doctor to ask deeper questions and ask for more information. So that's the test to the doctor agent. And then the context for the patient agent is all the family history, symptoms, information here. The measurement agent is like whenever the doctor said exam, this is this, right? Like order exam. And then the measurement agent will look at the information they have and then respond with the results here, like put the results here. And so you see all the prompt, they also put a variable as a target language, right? So here is also target language because they want to evaluate how the language, what is the diagnosis performance, how that vary by languages. So they insert target language in their prompt. And if the doctor requests some exam that does not exist in the existing information, then the measurement agent can just respond with the normal findings there. So doctor agent is the most complicated one because the doctor agent is in charge for the diagnosis, right? So you see the information over here. So you are expecting the patient. You are only allowed to ask. So basically, they also put the upper limit to the doctors here. And then also because it's a dialogue based, like each time doctor is using the same prompt. So you also pass in like how many questions you have already asked. And then if the doctor needs to request test or exam, right? So you can just say require test or what is the name of the test? Like require test, chest X-ray here. And then the doctor agent, so there will be some more instructions. So this is a research tool for the doctor. A doctor can do the web search, can do the textbook search, like the medical textbook search here, kind of the RAG search, right? And then the chain of source reasoning instructions with or without some examples. And then once the doctor is ready for the diagnosis, please say diagnosis ready. And then this is your diagnosis name here. And then below is all the information from the past dialogue with the patient and the exam findings, right? So this will be capturing all the known existing information about the patient and the context and the notes that the doctor has kept. Yeah, so, and also the doctor agent must discover their disease by asking them questions. It cannot be I see that there's no hard rules to prevent the doctor just referring some internet cases, and maybe they find some very similar case, they just use that instead of actually asking the patient questions to in order to reach the conclusion. But I think that will be a very good thing to follow up and to check the sequence of the question that doctor asked. And again, the target language is a variable here, right? And also the command will be also in that language, because they want to test if the patient only speak that language, then what is the doctor agent performance? Because a doctor agent, like they must speak and also make commands in the target languages in that language settings environment. So then the rest is what about introducing the tools that the doctor agent can access, right? So like the internet research prompt that you can perform this, do the internet search here. And you can do the textbook research prompt, like research textbooks, and this is the content for the textbook search. So this is like a kind of like a two rack, right? So one for internet rack, or maybe just one rack, while you have the internet sources and also the textbook sources. And then the chain of thoughts prompts. So basically you ask the doctor to do the step-by-step reasoning and logics. So this is a zero shot without any examples. You can also do one shot chain of thoughts prompt, like providing this is the example dialogue here. And then you demonstrate the example of what the reasoning look like, right? So considering this is symptoms, more lean toward a diagnosis of what, and like this. So this is more like the internal mind speaking, the mind speaking part of the doctor, like trying to reason about the information they see, and then the doctor, like after doing all the chain of source reasoning tokens, they say diagnosis ready. So this is the conclusion from that. So this is like a chain of thoughts prompt with some examples, right? Like what the reasoning looks like, and then what is the conclusion from the reasoning that leads to the final diagnosis. Yeah, so the doctor also has the tool to basically order test results, right? So all the available test results are not presented to the doctor like in the static Q&As, but the doctor needs to figure out what test result to order. So which more mimic the actual practice, right? So the doctor say, let's start with the basic blood test, and then they can say request test. So this is a command for the environment so that it can invoke the measurement agent. And then the measurement agent look into the context to see, whether there's a test results for complete blood cells. And then it's going to return the information to the doctor. So doctor will get that piece of information from the measurement agent. The last tool, I believe the last, yeah. So last tool is a little bit complicated prompt. I do not expect you to read all of that. I'm always amazed of how long prompt that they can write for the agent. But over here, the notebook, the idea of the notebook is kind of kind of like the sticky notes that you put on your skin. So for example, some common mistakes that you make, right? You learn from your past experience and then you set it up, you keep the notes of those and then keep it as a reminder so that you do not make the same mistakes again. So it's kind of like lots of sticky notes you put on the wall on the laptop. So it's the same for the doctor agent. So they provide a way for the agent to write a note. For example, the previous patient provide this. I should ask more descriptive questions to get better information. So this is the note that the doctor agent may conclude from the previous cases. So the idea of a notebook is to accumulate the experience of the doctor. So just as one, like you mentioned that the doctor experience will grow over time, right? So while the LLM is just like a simple Q&A and it heavily relies on the context it has. So over here is trying to mimic to accumulate that experience of the doctor by sharing the experience across the diagnosis experience. And the doctor needs to summarize what note they want to keep in their context, and they will reuse that note for all the future diagnosis. So hopefully that, I think this paper showed that it is very effective in the first few diagnoses. And then after that, it will saturate, right? So basically, it's kind of all the information, all the notes are already there, and then the doctor kind of the performance will kind of like saturate after the doctor has diagnosed, say, 10 cases. In the notebook in this paper, they also limit the length of the notebook. But I do think to make effective notebook, you may want to like build a memory for the doctor and do a rack, like kind of still like some additional source for the rack, right? As a notebook. But over here in this paper, they specifically limit to 1,000 charts. So it's just like 200 words. So it's quite limited. And also once the doctor rewrite the notebook, they will just discard the previous one. So the doctor needs to always write the new notebook using the previous notebook plus the information they see in the current diagnosis case. Yeah. And then the last one is the moderator, right? So it's the AI judge. So this is just to determine if the current diagnosis so this is the ground truth, and the doctor diagnosis are the same disease, and then just respond with yes or no. So this is the current diagnosis from the ground truth from the simulation, the clinical source, and then this is from the doctor dialogue, like doctor has made a conclusion there, and you can ask, are these the same disease? You may wonder why not just do an exact string search. Well, in practice, the disease may have slight differences, right? I would say, and I think we want to provide a more flexible matching rather than a hard string matching here. So this is about the prompts for each of the agent. And also, I think they also study the biases for the agent, right? Like the patient may have some recency bias. The recency bias is like, oh, my friend has something serious with different symptoms, and then they found out it was cancer. So basically, the patient, trying to uh, uh, share their feelings, right? Like because of the friends or relative, they try to share the feelings with the doctor, and then they want to see whether this will affect the doctor's diagnosis there. And also, of course, the doctor may also have the bias, such as the education bias. It may say, well, given your background, let me explain in simpler term. So instead of explaining the professional term, the doctor choose to explain in simpler term without too much information. And then how does this will affect the diagnosis accuracy? The patient may also have the self diagnosis bias, right? I think it's very common. It's like we trying to diagnose for ourselves. And sometimes we also mention this to the doctor, like I have this concern, I'm worried that I may get this or that, right? So the patient share the self-diagnosis information to the doctor. Well, does the doctor how much this information will affect the doctor's diagnosis accuracy? So I think this is all kind of the I will not say noise in practice. I will think this is all very realistic concerns, right? When we actually deploy say a doctor agent in practice, this is all very realistic information that the doctor agent is going to receive. And then in this paper, I think they define more than 10 biases. Yeah. I think they work with the hospital to design this. So I think they know what kind of information or biases that the doctor usually receive in their daily practice. So these are all I haven't listed them all here, but you can check in the paper, in the appendix, they have listed all the prompts for the biases that you can pass to the agent. So there's the patient bias, like the recency, frequency, self-diagnosis, right? Or gender bias. The doctor may also have the bias, like the recency. For example, the doctor diagnosed a similar case right before this one, so it may have some recency bias there as well. So yeah. And also confirmation bias, like the doctor may have some prior initial assumption, and then this may affect how that doctor is going to interact with the patient. So yeah, I think this is all very realistic and practical concerns. Yeah, so this is all the setup for the multi-agent framework, about the tools the doctor can use, about all kinds of the prompts, right, to simulate the dialogue, and also these bias prompts to introduce some biases to the doctor and the patient. And that will, of course, affect how they are going to interact with each other. So the paper want to see how this bias will also affect the model performance. So this results is a doctor agent diagnosis accuracy on the from the dialogue, right? Right now the doctor agent needs to interact with both the patient agent and the measurement agent, right? So right now, even though it's still sourced from the medical Q&A, but rather than presenting the full information to a doctor agent, right now the doctor agent needs to seek the information themselves. So yeah, so we will expect a drop of performance because maybe the doctor hasn't ordered all the information they need to conclude the diagnosis. So this is the use case from the source from the still the same static benchmark like medicine Q&A, but it's in the dialogue interaction. And then the best performing model is a Cloud 3.5. I know right now it's like 3.7 and 4 also coming out, but at that time of publication, the best performing model is Cloud 3.5. And then the second one, I think this is some open medicine LLM there, and also the GPT-4 over here. So this is so the patient agent, they use the GPT-4. So means that the patient agent, they use GPT-4, but the doctor agent, they choose like different LLM, right? So they can choose cloud, what is the performance, and they can choose open LLM, they can choose GPT-4, they can also choose Llama. So the doctor agent is the variable here, and then you will see what is the performance. So if you see that even though the medical Q&A, right now the performance is kind of around the 90% accuracy, right? In a static one-time Q&A. But if you convert that problem into a dialogue to ask the doctor to find out those information, the performance dropped from 90% to 60. Like I think this is a slightly above 60%. Which means that the sequence of decision of the doctor needs to be optimized rather than just like a one-time static Q&As in the regional benchmark. If you convert it into a dialogue-based process, the performance of this LLM all dropped greatly from here. And then you will see the second chart, like just these 3 bars, is you fix the doctor agent, like use the GPT-4, and then you use like these three, GPT-4, GPT 3.5, and this mixture model as the patient agent, and then you want to see what is the performance. So here, and then here, this chart is like you fix the patient agent, use GPT-4, and then the doctor agent, you select like a different LLMs. And then on this Mimi 4 performance, like a dialogue. So once this data sets prefixed with the AgentClinic, it becomes a dialogue, right, in that agent framework. Then yeah, it's even more challenging use case comparing to the medical Q&As. So the performance is only around yeah, just slightly above 40% accuracy on this benchmark. Yeah, so from these findings, I would say overall, there's still a big gap to close to convert from the one-time static Q&As to this sequential decision-making process in the multi-agent framework. Okay, does it answer your questions, or you have more questions, Wilson?
No, thank you so much that you explained. There was a couple things that I missed that you explained very well. Thank you.
Okay. Okay. Next, on the basically we break down the results according to languages, right? Like to learn English, specifically like learn English. Usually English is the best performing one. But if you change the target language variable in the prompt, like you ask the doctor to respond in French, Hindi, Chinese, Korean, Spanish, right? So the English, yeah, it will be I think this performance is normalized by English performance. So the English is always like the top. And then you will see the other performance kind of shrink. And then you see the Cloud 3.5 seems very strong in the multilingual setting. Well, I would just look at GPT-4. GPT-4 is actually GPT more better than GPT-4o. Because GPT-4 is more like a efficient version of GPT-4 and some multimodalities there. So if you look at the GPT-4, so it's over here. So you see it's yeah the performance shrink. Also because the English performance is lower comparing to Cloud 3.5. So I guess Cloud is pre-trained on lots of medical corpus, while GPT side is not that much. So yeah, so if you want to try LM, preferably use the cloud. I'm not sure about the most recent model for GPT-4. For no for GPT-4 like the GPT like O series, O1, O3. I'm not sure like whether they have improved the performance on the medical data. But according to this data, it seems like the cloud series of model has better knowledge on medicine knowledge, medical knowledge. And then the other question is on the specialty. Yeah, so they also, because their cases is also due to different specialties here. So it looks like the internal medicines and this performance are good. While the emergency is very low, right? And also this psychiatry is low. Yeah, maybe psychiatry is like more personalized, I would say. Yeah, so this specialty's performance is low, but like say internal medicine performance is good. I think this may be also due to the what data is used to pre-train and fine-tune the LLM, the corresponding LLM. So yeah, by using a LLM that is able to handle all different specialties, or you can just fine-tune one LLM for that specific specialty, can get you a better performance. Maybe like from here you can say, oh, internal medicine, the general LM is already good enough. I can just use Cloud 3.5. But for psychiatry, the performance is bad. I may need to fine tune another small, maybe not that big, but like a smaller special version of the small LM, small SLM for the psychiatry specialties. So this is also the tool use of the doctor agent, how effective the tool use is. Yeah, so it looks like the notebook is very effective. The book, textbook, and the web search, right, is yeah, it's also useful, but the reflection chain of source is not useful. Not as useful as the other tools there. That is also true. The emergency information may be also yeah, maybe it's also according to the practice, right? Because more maybe may require the experience of the doctor more, may demand that experience more than the other specialties that you can find in the textbook. Yeah, so and they also have done some comparisons with the benchmarks on the static medical Q&As and also the dialogue-based medical Q&A, right? So this is the new benchmark. And then so the medical Q&A, so you see the one-time Q&A, the performance is all very high, above 90% for this, for Cal 3.5 and GTP4. Well, if you change it to the dialogue format, then the performance also dropped. But they also say that the static accuracy is not predictive of any accuracy on this AgentClinic benchmark. Maybe because the capability required here is the decision-making process, right? So that is really not just the medical knowledge, but also the decision-making process, the decision-making capabilities of the LLM. So even though this Cloud 3.5, if you compare Cloud 3.5 and GPT-4, these two performance are close, maybe around 90%. But when it comes to this dialogue-based evaluation, Cloud will have a huge advantage over GPT-4 in this setting. And then the last is the biases, right? So yeah, there are different biases. I think this curve is corresponding to different models. They only study I don't know why they haven't studied Cloud, but they only tried the GPT-4 and the Mistral here. So like by introducing, so this is no bias. So if there's no effect of the bias, it should be as close to a circle as possible, right? But if there is a bias, then the performance will drop greatly. So if you see the GPT-4, the bias is actually not affecting the final conclusion of the doctor that much. Well, some is still affecting it, right? Some are still affecting it. But for the mixture, like a smaller model, it will affect a lot based on what the patient say to the doctor. If the patient, especially if the patient is bad, then the doctor may conclude differently. Or if the patient, the self-diagnosis is very strong, it may influence the doctor. Like if the doctor is a small LM, it may get affected easily by the doctor, by the patient. They also have studied the patient confidence rating, compliance rating, and the consultation rating. I believe these ratings are from real people. They connect all the dialogues from the doctor agent, this agent system, and then they ask humans in the clinic to just evaluate like how would you give a rating for this dialogue in terms of the consultation and compliance. And then they do notice that by introducing biases, these ratings may drop, even though the diagnosis is correct. But the compliance, consultation, empathy drops because of these biases there, which also makes sense to me. So, but I think the goal is clear, right? So we want to not only to improve the diagnosis accuracy, we also want to improve the empathy, including because the doctor is also as a service to human, right? So we want to improve this compliance consultation. The patient confidence is also like whether the doctor is able to earn the trust from patient, so that it will be also good for the health beings for the patient. And then they also study the multimodal input, like instead of just passing the findings from the images, what if they just pass the medical images directly to the doctor? And then they find that, yeah, so this is the initial presentation, and this is the measurement. If you present the images directly to this model, like who can handle images, because some model are not able to, but like the GPT-4, GPT-4o, Cloud 3.5 is able to handle images. You can present these medical images to that as well, and it does help a little bit on the performance. side. So I want to discuss a little bit because right now we see in this benchmark, the accuracy is just around 60% accurate. So there is still a big gap to close. Like even if in the simulation environment, if the accuracy is above 90%, I wonder that when the doctor agent interacts with the real patient, the performance will also will drop because the real patient is not going to follow the instruction as strictly as the patient agent in this system, right? So the first goal will be in the simulation setting, we want to improve the doctor agent's performance. And then we will want to improve the robustness of that so that in the clinical setting, in the real world application setting, the doctor agent should be prone to those additional noise, additional noise and biases they see in the dialogue so that they can still persist the high performance in the accuracy. So in terms of the limitation of this, I think first is the sequential information gathering. Because the clinical process is a sequential decision-making process. It's not like a one-time Q&A. And maybe this is also related to reinforcement learning, is how we can optimize the sequence of action rather than just one-time Q&A, right? So I think like maybe we may want to focus on this sequential action optimization settings if we want to further improve the performance of the sequential decision making. And then there will be some cognitive and implicit biases from both the patient and doctor. It will reduce the diagnosis accuracy, and by how much it depends on the model, right? If you use like the GPT-4, like a very big model, the impact is smaller than you choose a small model. The tool utilization, I think there's still a gap. Not all models can effectively use tools. For example, a less powerful model like GPT 3.5 even see declining performance with some tools. So if the model is not powerful enough, by providing them tools, it's just noise to them, and you will even decline the performance. While the other more powerful models like Cloud 3.5 is able to benefit from the tool use significantly. And we may also want to improve the tool itself, right? Not just the tool utilization, but also tool itself, whether the rack is efficient, whether we can create a very effective notebook for the doctor, right? To accumulate the experience for the doctor so that they can improve over time, just like a real doctor in practice. And then, yeah, so the model quality, of course. So the model quality matters a lot for that. And I do see the like Google, IBM, and many other are developing just special LLM for medicine. And then there are complex case scenarios like specialists, like the emergency medicine, right? So it's still very poor performance, and also psychologists, it's still very poor performance. And also there are multimodal cases, which require visual interpretation of the images, which will also require more fine-tuning of the model to understand the medical images. Yeah, so the top performance show much lower accuracy in the general text-based Q&A. So if you add those medical images, you still present more challenges comparing to just text-based Q&As. There will be also the dialogue realisms that doctor agents sometimes can still make basic errors. We cannot fully solve the hallucination, right? And also it may skip the empathy and just focus too narrowly on the subject, on things at hand. And then it may affect both the diagnosis reasoning process, and also it will affect the patient trust. That that the patient just no longer wants to talk to the agent. And I think it's also like when you talk to a chatbot right now, sometimes, especially the customer service, right? If it's not able to directly solve the problem for you, you will quickly lose trust and just say, I want to talk to a real person. which I think this is still a problem. Like to solve, or well, maybe it's just a process to build to see with the help of the AI, how can we still establish a process that can maintain the trust, right? Like at some place, well, the AI can make more quicker and effective decision that them do that, but in some areas, well, the patient can still get the benefits from the real doctors when needed, so that the system kind of gains the trust from the patient. So at least from this point, I do not see the doctor fully out of picture. I still see there's a long way to go to really build out this accurate and empathetic system there. So the conclusions, yeah, realistic benchmarks are very important. No matter what you do, no matter what chatbot, what AI use cases you develop, uh, yeah, build the right benchmarks for your problems. So you see from this paper, like switching from the static Q&As to the dialogue based, the performance dropped greatly, right? So you may want to select the right benchmarks that reflect the actual settings of the real world problems. And to summarize from the previous limitation to improve, we need a more powerful LLM or vision language model to handle the modalities. We need a better tool design and utilizations. We want a model to optimize for the sequential decisions rather than just one-time Q&A and one-time prediction. We need the model to be robust to the biases and also show empathy to earn the human trust. So this is all needs to be considered and yeah, I would not say like a 100% solved, but at least tried and to be solved as much as possible as we can, so that we can roll this service out to really help the clinical settings.